we're going to go on with our program. And our next two speakers are Dr. Charles Louy and Dr. Marcel Maya. Dr. Maya already has been introduced. Dr. Louy has written a lot on his website to introduce him. So I will not do that. And I will just say that Charles and I have been working very, very closely together, trying to help people with spinal fluid leaks since, I think, the year 2000. And he's just a terrific anesthesiologist as well, and he cares very, very deeply about the patients, but also about better ways to trying to treat them. Charles?
Thank you, Wouter, and thank you to Connie Doline and Dr. Shivink as well for inviting me to this presentation. So today I'd like to talk, I'm going to say a few words about, how does this go back, I guess? Oh yeah, you first. I'm going to say a few words about high volume epidural blood patches. But before I do that, we already had a discussion, I think, with I think it was Dr. Levin, where we talked about how to increase intra-abdominal pressure to make a diagnosis, confirm a diagnosis of intracranial hypotension. And this is what I have devised because I believe in this technique. I stand behind the patient and wrap around my arms and progressively increase the pressure until the patient's symptoms are improved. And if they do improve when I do that, and they get worse when I release the pressure, then I have a confirmation that the patient has intracranial hypotension. And you know, sometimes, anyhow, I'm going to leave it at that. Sometimes it's not possible to do that, so a modified version of this is the patient in the recumbent position. I apply as much pressure as I can, obviously within a certain limit. And so that has been a consistent way to confirm the diagnosis. For those of you who are not familiar with epidural blood patches, I didn't know who the audience was when I put the slides together. It's a percutaneous injection, obviously, and the tip of the needle is goes into the epidural space. Blood is injected in the posterior epidural space with the idea that it's going to spread cephalad and caudad to this injection site, and hopefully with the idea that it would actually wrap around and then go to the anterior epidural space. This is a patient who's undergoing a thoracic and lumbar epidural blood patch under fluoroscopy at our institution. And this is a close-up. The needle on the left is in the thoracic epidural space, and the needle on the right is in the lumbar epidural space. We talked a little bit about the mechanism today, and obviously some of this is speculative about what's causing there's an immediate improvement in symptoms, and whether it's an increase in CSF pressure or in a change in compliance, something is happening there. I think it's probably a little bit less controversial about the delayed benefit. What we're hoping to achieve with epidural blood patches is to have the blood spread and clot in front of and create a plug where where the CSF was leaking before the epidural blood patch. Historically, physicians doing epidural blood patches had been using preset volumes anywhere from 10 to 20 milliliters, but given the variability in the spinal canal elastance and the variability in the epidural volume, some authors have advocated the use of large volume epidural blood patches, and the definition of large volume is greater than 20 milliliters, whereby the volume injected in the blood is limited by the development of back or radicular pain. And I give you a reference there. So when we started doing epidural blood patches, when I started doing them for Dr. Shivink, we were doing low thoracic epidural blood patches. And then we noticed that in a significant percentage of patients, the symptoms reappear within a few days. So we brought these patients back and started doing, and did an additional lumbar epidural blood patch, and then noticed that the significant percentage of these patients responded to this additional lumbar epidural blood patch. And so whether the blood was pulling from the thoracic area down to the lumbar area, or for whatever reason, we then decided that it made sense to do simultaneous thoracic and lumbar epidural blood patches. I'm sorry, I went the wrong way. So, and we tell the patient that what they do, the activity levels that they follow in the 8 weeks that follow the epidural blood patch is as important as what we do during the epidural patching. So we asked them to avoid any activity that requires sudden contraction of the abdominal muscle. So minimize coughing, sneezing, that obviously they don't have a full control. And we tell them to do no sudden bending, no sudden twisting, no running, no jumping, no bumpy rides. In general, avoid high-impact exercises. And then we had 2 patients whose epidural blood patch failed immediately after sexual intercourse. And so we restricted sexual intercourse to the woman on top and man on bottom position. And people then ask me, well, does it depend on who's leaking? And the answer is no, because in that position, sexual intercourse does not require sudden contraction of the abdominal muscles. So as importantly, we ask patients to prophylactically prevent constipation. So we recommend polyethylene glycol once a day. They skip a dose if they start having loose stools. On the other hand, if they're still constipated, we ask them to add a tablespoon of mineral oil twice a day until they have the first bowel movement. And we also warn them to stop taking the mineral oil after the first bowel movement, because otherwise they're going to start becoming stool incontinent. We told them to avoid laxatives that cause cramping, such as Bisacodil, Senna, enemas, because that causes cramping, and that would defeat the purpose. We told them to avoid opiates because they can develop a secondary constipation or a secondary headache, which confuses the picture. And unless contraindicated, we ask them to avoid anticoagulant, including aspirin, ibuprofen, naproxen, etc. So here's the data. For the first 9 years that I did these epidural blood patches, from 2001 to 2010, I treated 94 patients with SIH with 163 epidural blood patches. The mean total volume per EBP was 43 milliliters plus or minus almost 22 milliliters, with a range that went anywhere from 4 to 124 milliliters. And the reason one was as low as 4 is because the patient developed radicular symptoms, even just at 4 milliliters. The responder rate was almost 29% after the first EBP, and 41.5% and almost 47% after the second and third epidural blood patch. There was a significantly higher prevalence of subdural fluid collections on MRI in the responder group, 48% versus 18%. It's difficult to compare our outcome data with the published results because many of our patients have failed epidural blood patches elsewhere. The duration of symptoms is an important variable, and the average duration of symptoms prior to the EBP in our series was 1.9 plus or minus 4.2 years. Now, Senkakova and colleagues show that patients who respond to the first EBP have a significantly shorter duration of symptoms. Again, confirming that it's more difficult to make a comparison from one series to another. Most of the patients in our series had an orthostatic headache, like Dr. Shiving talked about this morning, and as a main complaint. But in none of these patients was that the only complaint, and it's possible that these other symptoms may be less responsive to epidural blood patching. I took a six-year hiatus from doing large volume epidural blood patches, and I started again last year. And since in the last 17 months, I guess, I did 106 large volume epidural blood patches. And the mean volume was, again, 31.5 milliliter plus or minus 19 milliliter with a range between 4 and 99 milliliter. I don't have any outcome data on this most recent series. So Taiwan and colleagues wanted to study the efficacy of blood patching by using different fixed volume. And so they patched patients with a certain volume, then they repatched them with a larger volume. I mean, not necessarily the same patient. And they were not able to show a difference in outcome. Again, supporting the idea that one should inject blood until the patient develop either back pain, radicular pain, or we used as other limiting factor as a patient can develop increased pressure in the head, or popping of the ears, or changing hearing level. And in fact, this morning somebody asked whether we treated a patient, we were able to restore hearing level in the patient. We had one patient who had complete hearing loss on the right side, I believe, and she was able to recover partial hearing just after one epidural blood patch. Now, there's been, more recently, there's been more and more reports of people doing high-volume epidural blood patch. Grioz, who's a neuroradiologist, and colleagues developed a catheter-based protocol for patients with SIH that resulted in an average volume of 54 milliliter per epidural blood patch. And they report that 8 out of 9 patients had improvement or resolution of their symptoms. More recently this year, Wu in Taiwan and colleagues did a retrospective analysis of all the patients who underwent epidural blood patches in the Veteran Administration Hospital in Taipei. These were all inpatients. And they looked at the factors predicting the response to epidural blood patches, and one of the factors was the volume of injected blood, the 22.5 milliliter being the threshold. And they injected up to 55 milliliters. And fresh off the press from London, Ontario, there was a case report, again, of a patient who had developed severe neurocognitive dysfunction, and they were able to treat that patient with a series of 3 epidural blood patches, what they call ultra-high volume. Each volume ranged anywhere from 60 to 120 milliliter. What they did is they inserted a catheter in the lumbar area and threaded it up to the upper cervical area and injected anywhere from 2.5 to 5 milliliter per level. They repeated the procedure on 2 other patients, but they don't have the long-term outcome result on that patient. And here's the list of my complications. Going retrospectively, I have about 2.6% wet taps, unintended dural punctures. None of them had any long-term effects. 2 patients developed radicular pain that lasted 2 and 4 weeks respectively, and then had complete resolution. One of our patients in home with repeated and large volume epidural blood patch 3 days after a prior blood patch developed bilateral paraplegia, which resolved completely within 20 minutes. And the most severe complication is a cauda equina syndrome from arachnoiditis, which was associated with urinary incontinence for 4 years. And in that one, when I went back and looked retrospectively, I missed the fact that the needle was in the intrathecal space. And so therefore I injected blood unintendedly, unwillingly, obviously, in the CSF. Based on the complication, I recommend the following safety protocol. I think there should be a radiographic confirmation with a contrast injection of the epidural placement prior to injecting blood. That may seem trivial to you, but at that time, as of a few years ago, we had reports of anesthesiologists around the country doing these epidural blood patches without imaging and doing high volume as well, which I think I don't recommend. I think the other issue is that the protocol that I've adopted is after injecting 20 milliliter of blood, in order to continue injecting, I require that the patient meet one of 2 criteria. if the patient has to report either some kind of radicular symptoms or back pain or increase in head pressure or something which would confirm that the needle is still in the epidural space. If that criteria is not met, when I inject blood, I use a constant pressure on the plunger of the syringe. And if the pressure does not, to maintain the infusion rate at the same level, constant, does not increase, then I inject contrast through the needle to reconfirm that the position of the needle is still in the epidural space. And then, of course, the minimum time between consecutive high-volume epidural blood patches should be at least 5 days. And since we adopted this protocol, I haven't had any other complications. So, in conclusion, high-volume epidural blood patches can be done, but we highly recommend that fluorescence imaging be used in conjunction with the epidural blood patch, during the epidural blood patching. And 2 potential complications need to be kept in mind. One is the unintended intrathecal injection of blood. The other one is a potential the radiculitis that the patient can develop, which leads to, with as little as 4 milliliters of blood, which implies 2 corollaries. One is the patient needs to be fully awake to be able to give you continuous feedback. Otherwise, there's a potential of causing some long-term damage. Yeah, I think that's all right. There was another thing I wanted to say, but I think that's about it. Yeah, and I was going to say, because you need to keep in mind there's a great variability in the compliance of the epidural space. This is my contact information. If you have any questions or concerns, if you send me an email, please include the email of the assistant, because sometimes I actually junk and I delete some emails because I think they're junk mail. Thank you very much.
Thank you, Charles. So as Charles indicated, blood patch remains the main first-line treatment for CSF leak, and it may be done with single-level, multi-level, or targeted blood patches, as we'll see later on. And I want to spend some time talking about Fibrin Glue and how we use it. Back in 2003, when I had black hair, so Wouter asked me to do a fibrin injection on this patient with CSF leak. And with a transforaminal injection, that was the first one I did. And the guy did very well. We didn't see him follow up recently, but he's doing all right. Since then, these are the last 4 years, the numbers we did. We do approximately 170 to 200 blood patches a year, and approximately 45 to 50 fibrin glues a year. I don't have results as nicely tabulated as Charles has, because it's a mixed group and it's very hard to keep track of the outcomes, but we have some ballparks. Show you a couple examples, a few examples here. This is a middle-aged woman with multiple diverticulum, as you can see. She's had blood patches without much success or limited success. And she had this obvious large diverticulum, which we targeted. And we do them under fluoroscopic guidance with a transforaminal needle placement. Oops, that's not what I wanted. Okay, here you go. And I don't know why it's not working. but we inject the contrast to confirm where we are in the cyst, and we outline the cyst. And generally, it's very stagnant with a large cyst like that. And sometimes I just pull back a little bit to get into the epidural space. And once we have the proper position, inject the fibrin glue. We use fibrin, the Tissile product, which is ready-made and frozen, and we thaw it before the procedure and mix it up. It sets pretty fast, but if injected through a 18-gauge needle, it's not a problem, and it sets rapidly. I showed this patient earlier this morning for diagnosis. This is the one with the sacral cyst, and I did 2 levels of fibrin glue injection for this patient, again with transforaminal approach. You can see the cyst being outlined with the contrast at these 2 levels, and she did quite well. This patient had multiple meningeal diverticula, and we targeted these lower ones prior to surgery, again with transforaminal fluoro-guided needle placement, confirmed with contrast. You can see the contrast lining up, outlining the cyst on AP and laterals. And once we have the confirmation, then we inject it. Generally, per level, inject 2 or 3 cc of fibrin glue mixture, which allows us to place 3 to 4 levels, given that volume. The Duke team will talk about the targeted approach, but we've done some for patients who have ventral epidural leak. The fluoroscopic guided approach is not very safe there. That has to be done under CT. So we find a position right in the ventral leak where in front of the thecal sac and inject the fibrin glue material. These are high numbers for epidural blood patch, but it takes into account to all comers rather than recalcitrant and tertiary referral patients. Percutaneous glue is not as effective, but it does have a real good chance of providing long-term benefit and cure. Thank you very much.